And let's turn now to our speaker today, Dr. Tim Kosinski. He is a highly sought after speaker and teacher in the world of implant dentistry and one of the most popular speakers that we have on our Friday study club. He's taught hundreds of courses, written dozens of articles, and been a mentor to so many doctors as they enter implant dentistry. He's also the editor of General Dentistry, which is the official journal of the AGD. And he's going to continue today his discussion of immediate implant placement after extraction. Tim, it's all yours. Thank you so much.
Well, thank you. Thank you, Dr. Park and Nicole. And I think we're good, right? We're good.
Yes, perfect.
And thank you. It's really an honor to give a part two. Nicole, you sent me some really nice comments, but we didn't give everybody enough information, and people wanted more. So let's continue our discussion on dental implants, immediate placement. And as most of you know and have heard me say, I'm not a big immediate load person. I like one-stage surgical procedures. I like immediate placement of implants. But that's just me. 39 years, we're close to 19,000 implants, Dr. Park, that we've placed over our career. And I do have a tendency to be rather conservative. Now, we're not talking full arch things where we have an arch form, but let's talk about more simple cases that you're seeing in your practice every day. Today's Friday, it's my day off, but on Monday. And again, my practice is outside of Detroit, in the suburbs of Detroit. I have a lot of dentists around me. We have 99 dentists in a 10-mile radius from my practice. So we don't compete. We educate and instruct, and there's a lot of dentistry that needs to be accomplished. And hopefully this short time that we have together will stimulate your thought process in getting more information, maybe incorporating procedures that you don't normally do in your practice. And the symposiums at Glidewell are just exceptional. I learn something every time I go to one of the symposiums. And this is beautiful Lake Michigan, up in northern Michigan. And real briefly, our objectives, again, this is part two. We're going to learn some atraumatic or minimally traumatic extraction techniques to preserve bone. Bone is gold to me, especially in implant dentistry. Socket preservation is a critical part, an integral part of implant dentistry today. You have to feel comfortable reflecting tissue properly. Grafting, we have two different materials that I'll demonstrate today. With allograft materials, we must protect the graft material from invagination of epithelium. So we have to properly, passively place a membrane to prevent invagination of epithelium and allow the graft to integrate into bone. And for those of you who've heard me before, the techniques that we demonstrate, we can grow bone 100% of the time today, 100% of the time. That is such a bold statement to make, but the grafting procedures that we're doing, the materials that we're using, give me a lot of predictability in preparing a site for a future implant. Immediate implant placement, to me, is very, very important. We take a tooth out, we have a socket. That socket is shaped like an egg. Our implant is round. I will tell the patients we are placing a graft material, explain the materials that we're using, and thread the implant directly into that site. Depending on the torque that we receive or the patient's habits, whether they're smokers or not, will determine whether or not we can do a one-stage procedure, meaning placing a taller healing abutment, allowing the tissue to heal around the implant, or if we're going to bury the implant and allow the epithelium to grow over the top, and then in the future, at some point, come back, uncover the implant, and start our impression process. And we have to understand the different types of tissue out there. And I hope we're able to get that to that today, Nicole. If not, we're going to have to do a part three. But there must be attached gingiva on the facial aspect of all our implants, required, no exceptions. And if we do not have attached gingiva, we know when teeth are lost, bone is going to shrink down and in the lower jaw, up and in the upper jaw. And oftentimes the mucosa will follow that shrinkage of the hard tissue. We must have attached gingiva on the facial aspect of the implants, and hopefully I'll be able to demonstrate that clearly today. Let's keep moving on. We talked about this briefly last time. Grafting is a critical part of implant dentistry. It helps minimize bone loss, helps support soft tissue architecture, maintains periodontal health, and it can provide an adequate site for my implant placement in a short 3 to 4 months, depending on the size. If we don't graft, the literature will say epithelium will grow into the socket. We may lose more bone ridge height and width, which may inhibit or prevent ideal implant placement. And the literature says without grafting, we will get 30 to 60% bone loss in those sites, which may require a more invasive grafting procedure, a much more invasive surgical procedure, and a much more expensive procedure to build that bone. Things that we're seeing all the time in our practices. If we use an allograft, we're using a resorbable membrane from Newport Biologics from Glidewell. I only have one membrane in my practice. It's a 3 to 4 month, very high quality, purified intact collagen from porcine peritoneum. It's very easy to manipulate. If I'm using a membrane over a graft, that membrane must remain intact for at least 6 weeks. 6 weeks. It cannot be dislodged. It cannot be removed. If it is dislodged or removed, then the case becomes unpredictable. Then I can't tell you if we're going to have bone growth 100% of the time or bone replacement 100% of the time. So the techniques that we use in positioning, passively positioning a membrane is critical to our success. The allograft material, again, that I use one allograft from Newport Biologics from Glidewell. It's a cortical cancellous particulate. It is osteoconductive. It allows me to objectively determine bone turnover with my digital radiographs, and allows me a very, very precise, accurate, efficient means of grafting a site and holding the bone level at a certain site in a certain position for ideal implant placement. The other material that I use is a synthetic. You've heard me talk about that. It's called Osteogen, again, available through Newport Biologics and through Glidewell. It is a bioactive crystal, calcium apatite in a bovine Achilles tendon matrix. We do not need a membrane, and this is my graft material of choice when I have a socket that is intact, meaning all 4 walls are intact and I intend on immediately placing an implant. So it allows me to simply place a very inexpensive material into a socket, and it allows me to thread my implant after preparation into that socket site. The graft then acts like caulking, filling the gap between the implant body and the walls of the viable bone. It is simple, easy, and affordable to use. And I use this material just about every day in my practice. Let's get into some clinical. We have a situation where we have a tooth that's deemed non-restorable, root canal treated tooth. Our endodontist says, go back to Dr. Kosinski. We really can't retreat this tooth, and we're going to remove this tooth. How do most of you remove teeth crowns today? I'm probably, it's a rhetorical question. We take some type of burr and we make a cut through the facial onto the occlusal, onto the lingual in this situation. We take some type of instrument to remove. Usually the mesial portion comes off, the distal portion stays on, and we wrestle with it. It's time consuming. What if it's a Bruxer crown, a zirconia crown? Very challenging, very time consuming to remove those crowns. This is a instrument, a set of 3 instruments. They're called WAM keys, W-A-M-K-E-Y. You can Google it. And what I will oftentimes do is, I know this preparation of this crown probably is 2 millimeters apical to the coronal portion of the crown. So I will simply make a window, an elliptical window through the crown to the central groove area. We then have this very high quality stainless steel instrument, WHAM key, Google it, and I will simply place it into that little elliptical opening. It's a set of 3 keys, very inexpensive, and I will simply rotate my wrist, and that crown will pop off. It is so time saving in my practice. So in this particular situation, we have a bifurcated mandibular tooth that is damaged, needs to come out. I will almost always section my mandibular molar teeth and section it through the furcation area and then remove the teeth as if they were 2 single-rooted bicuspid roots. Make sure you are all the way through. I'll make sure I have a little movement. Little bit of movement there. Make sure radiographically that I did cut all the way through the furcation. And these are called physics forceps. You may have heard me talk about these before. I use these every day in my practice. Again, if you Google physics like PHYSICS, forceps, it's a set of 4 instruments, upper anterior, upper left, upper right, and lower universal. I will then engage this instrument. I don't want to take a lot of time with this, but it consists of 2 components. The shovel-shaped beak will engage in this situation, the lingual aspect of the tooth, 1 to 3 millimeter subgingival, and the bumper is not the working end of the instrument, will be placed as far down the vestibule as possible, and it is simply acting as a fulcrum. It's not holding the facial plate. It's simply acting as a fulcrum point. And with simple rotation of my wrist, no squeezing of the instrument, I'm simply rotating my wrist, creating tension on the lingual aspect in this situation, following that arc of rotation of this specially shaped instrument, and without any, really no forces on this other than rotation of my wrist, that tooth will pop out in a matter of seconds. Now, the instrument is not intended to remove the tooth in total. Rather, it's intended to luxate the tooth up and out of the socket about 3 millimeters. I will then take what we call a tooth delivery instrument, like a bird beak forceps, and remove. Always take a radiograph following an extraction. Well, I want to make sure that I did not leave any root fragments or bone fragments in that socket. I say this because I see it all the time. Root tips are left in the jaw all the time, which makes our placement of dental implants very challenging. I'm then taking this osteogen plug, this synthetic material made in a laboratory, calcium apatite in a bovine Achilles tendon matrix. Now remember, bone is calcium apatite. And I'm simply placing it into those 2 sockets, placing it firmly to the crest of the ridge or slightly above the crest. I take a radiograph. This is immediate. You can see the radiolucency, immediate placement. Suture over the top. I did not need a membrane with this. The epithelium has 2 options here. It can go into the material or grow over the top, and the epithelium is always going to follow the path of least resistance. Now, critically here is trying to maintain the attached gingiva on the facial aspect. So I do not want primary closure. I don't care about primary closure. I'm more concerned with attached gingiva on the facial aspect of this implant area. I don't care about primary closure. We see a significant opening on the crest. Epithelium physiologically is going to grow a 0.5 millimeter a day. So when I see this patient back in a week, I'm going to expect that we're going to get nearly complete closure. Depending on the size of the socket, it may take a little longer than that, but I do like to see my patients, my surgical patients in a week, just to see how they're doing, how they're maintaining, how they're taking care of their mouths. After 3 or 4 months, I can digitally radiographically, or here I take a CBCT analysis of where I want to place the implant after a quick 3 months. Now, remember, we talked about this last time. Physiologically, our graft material is going to turn over faster in the apical section and less quickly in the coronal section. So I expect more radiolucency in the apical third, apical half, and less radial opacity in the coronal half. But that's okay, because after 3 months, I'm going to make my osteotomy and I'm going to remove most of that bone anyways. And again, remember physiologically, our initial stability, our initial torque with any implant system is in the apical 2 millimeters. So now we've made a concentric circle here. We had a bad site, we grafted it, we can evaluate it radiographically, expecting more radial opacity in the apical third, apical half. We're going to do our osteotomy and we're going to get our initial stability from the apical 2 millimeters. So this is a very safe process where we can really control when we want to place our implant. And let's just do a quick video demonstration. We have a site. Now I'm evaluating attached gingiva. How do we do that? Now remember, I never blocked my implants, so I'm going to inject my septicane here into the vestibule, and I'm watching the mucogingival line. I'm watching that mucosa bubble up with the liquid that we're placing in it. You're evaluating very carefully. Do I have a band of attached gingiva of at least 2 millimeters? That's not a lot. I'm then going to walk up the site and I want to blanch that tissue. Now, I'm going to reflect here. So I'm taking what we call an Orban knife. It's a very specially shaped instrument, stainless steel blade, and I'm respecting the band of attached gingiva. I did not make vertical incisions. I'm making what I referred to last time as an envelope reflection. Doctors, this is real time. This is not a challenging thing. And I'm evaluating, number one, the band of attached gingiva. And what do we have there, doctors? This is not magic. This is something you're going to be able to accomplish routinely and predictably by following certain rules. With the Hahn implant system, I will then take a 1.5 diameter pilot burr. I'd like to use 2 hands here if I could, but with video, it's a little challenging. A 2.4 diameter, which is establishing mesial distal and depth. I'm using the apices of my adjacent teeth as my guide. It's a safety net. And you can see the amount of converted bone may not be completely mature, but adequate for me to place a dental implant. This is my favorite burr in the Hahn implant system, the 3.0 diameter. It has 1 line on it. I'm doing my radiographic measurements, and you can clearly see 1 line, doctors. And you can harvest that bone, and then I'm simply going to widen the osteotomy. 3.5, 4.3, 5.0. Again, I didn't really want to demonstrate too much surgery here, but it's important that you see that you can harvest that autologous bone. 4.3 diameter. This is real time. These are seconds to place a dental implant using the Hahn implant system from Glidewell. Beautiful, beautiful bone. And in our final 5.0 diameter by 10 millimeter long, respecting attached gingiva, respecting the facial plate of bone by reflecting in an envelope without vertical incisions. It allows me to reposition that reflection easily. I'm slowing down my motor to 25 RPMs, placing the implant in an ideal position, thinking tooth first, tooth up, and I'm torquing the implant to the crest of the ridge. Because I was able to achieve at least 25 Newton centimeters of torque, I am now doing a 1-stage procedure. A 3 millimeter tall healing abutment is placed at the slightly above the crest 2 sutures, 1 week post-op, respecting attached gingiva on the facial aspect, taking that healing abutment off. After 3 months of integration, you can see the periodontal health. You can clearly see that I have a band of attached gingiva. These are successes. This makes you an exceptional implant dentist. We're going to scan this. We put our scanning pin in. We scan. We now have a mill in our office. We can do or send it to the lab virtually. The laboratory here fabricated a screw-retained implant Bruxer crown that we will cover over with a composite resin, check the occlusal contacts. We now have a healthy situation, replacing the tooth effectively, cost-effectively for the patient, and providing a service that your patients are demanding at this juncture. Let's do another quick video in the anterior region. This is a tough situation. As you can see, we had internal resorption. Patient came in as an emergency patient. What do we want to do? Has issues. We're going to anesthetize the area. I'm going to use my physics forceps to atraumatically remove this tooth without squeezing in a matter of seconds. Simply rotating my wrist, one finger rotating towards the right nostril. The tooth will pop. This is real time in a matter of seconds. I'm taking a tooth delivery instrument and removing this tooth atraumatically. Now, doctors, we want to evaluate the facial plate. Do we have a facial plate? Yes. Do we have attached gingiva? Yes. Those are 2 things we have to look at. We're then going to take a motor, and I'm going to strategically position the implant. Now, there's rules to be followed in the aesthetic zone. My osteotomy is not in the socket. We must maintain 1 to 2 millimeters of facial plate. Rather, we're positioning our burrs 3 millimeters palatal to the facial aspect of our adjacent teeth to allow room for the abutment and final restoration. We're widening the osteotomy. Now, in an immediate placement, we want our implant to be 1 millimeter subcrestal. Here, I'm taking my osteogen plug. It can't be any simpler than this, doctors. This is caulking, filling that site. And I'm going to determine which implant I want to place. 1 millimeter subcrestal, threading the implant into position, 3 millimeters palatal to the facial aspect of the adjacent teeth. Now, remember where our stability comes from, the apical 2 millimeters. And this hole, this socket is shaped like an egg. It's bigger than our implant. And we're going to torque. We torque to 25 Newton centimeters. I'm going to put a cover screw. I'm going to bury this implant. The patient has some habits that we don't agree with. So I'm going to then put a little collagen plug over the top to protect the implant from tar, nicotine, heat generated from smoking. Just covering it over. This will not form bone. It's just kind of protecting, because again, I don't care about primary closure, doctors. I care about a band of attached gingiva on the facial aspect of the implant. My stability is from the apical 2 millimeters. The implant is placed 3 millimeters palatal to the facial aspect, maintaining 1 to 2 millimeters of facial plate. And here we just made a flipper appliance. Another quick video here. We have a tooth that is deemed non-restorable from our endodontist. You can see it's root canal treated tooth. I don't know how most of you feel. I have never seen so many fractured teeth since COVID. I think everybody's stressed out. So we remove this tooth that was fractured. We evaluate the site, make sure there's no roots left. And I'm going to make my envelope reflection. No vertical incisions. Most of us were trained to make vertical incisions. Doctors, if you do not incise into mucosa, you will not have the post-operative discomfort that you may be experiencing with some of your patients. Prostaglandin and histamine is not released, and we don't have that discomfort post-operatively. So we're able to give 600 milligrams ibuprofen. 800 milligrams is no more efficacious than 600, and the patients cannot get on with their life. So here I'm simply reflecting the envelope on the facial because I need to make sure that I have a facial plate. Doctors, my failures, nearly 19,000 implants, are because I place my implants too far facial. So reflect and see it. Know exactly where you are. Some of us are using robots now to help us, but it's very, very critical that we maintain attached gingiva and we maintain facial bone if we can in this socket. I will then go through the osteotomy procedures. We've showed this ad nauseum now. Small burr. I'm going to go a little quicker here. And we're determining what the tooth is going to look like. Anybody can put a screw into the bone, but thinking tooth first. Think tooth first. I'm then going to widen the osteotomy, trying to get my stability in the apical 2 millimeters, using the apices of my adjacent teeth as my guide, and then simply widening that osteotomy. Widening the osteotomy. Now here I'm going back to my osteogen. I've made my osteotomy, and I'm going to fill that socket with our caulking material that will convert to bone. Just very slowly placing it into the site and threading the implant into the site. Excuse me. Excuse me. Now remember where we want to be. We have facial plate. We're filling the defect. We want to place this implant 1 millimeter subcrestal. Physiologically, we expect a little bit of bone loss there. I got it in as tight as I could with my hands, which is usually about 15 Newton centimeters in a male, maybe 10 to 12 with a female. I'm taking my torque wrench. I'm looking at position. Take radiographs if you need to. Position is key. Going to just make sure that I get position. I don't care so much about torque. I care more about position. So it clicked. We're now going to 25 Newton centimeters. And I'm going to evaluate the site. Now, when I made a bit simple reflection, I can clearly see where the implant is placed. I'm going to put a cover screw here. And again, I'm just going to bury this implant. I didn't get a lot of torque, but I did get 25 Newton centimeters of torque. And I'm evaluating the soft tissue. Doctors, please evaluate the soft tissue. If they are a smoker, take a collagen plug from Newport Biologics and just place it on top to protect the implant. Again, I don't care about primary closure. I care about positioning of the implant and respecting facial plate and attached gingiva. So this is just a little Band-Aid, so to speak, to protect from bad habits. Give it a squeeze. This is immediate post-op. We're then going to suture. Now, because I have something on top, I'd like you to suture from crest to facial. We have reverse cutting needles in dentistry, And most of us were trained to use that suture from facial to palatal in this situation. And oftentimes we will grab onto a membrane or grab onto our Band-Aid, so to speak. And when we remove the sutures, sometimes that membrane comes out. We can't have that. Remember, that membrane must remain intact for at least 6 weeks to give efficiency and predictability with our graft. So go from crest to facial, turn that reverse cutting needle around, go from crest to palatal, and then tie your interrupted sutures. Again, I don't care about primary closure. Epithelium will grow 0.5 millimeter a day routinely. We see the implant is 1 millimeter subcrestal. 4 months post-op, we will uncover. Here we did an analog impression, put a healing abutment, and this is how all our Han implants heal. And a screw-retained implant prosthesis, which now looks better than conventional crown and bridge all day long. Something certainly within your wheelhouse that you're able to accomplish. Neil, I'm going to just take a few minutes here and run through this attached gingiva just one more time. I'm going to run through it quickly, and then I know we're going to have questions because I know I talk
No
really
problem.
fast. So here we have an edentulous site, and the patient presented for one implant. You can see we have some periodontal recession in the most posterior natural tooth. Let's ignore that for right now. We don't have a lot of ridge to work with. So here I'm going to do my CBCT analysis, and I'm going to work with Glidewell to fabricate a surgical guide. All our surgical guides are bone level. In this situation would be tooth and bone level, but I was able to place the implant using Glidewell's help, the team at Glidewell's help, to make a surgical guide. It's not what I really wanted to demonstrate here. The implant is placed, respecting the inferior alveolar nerve, looking at the apices of adjacent teeth as our guide. We now have an implant that we suture. 2 weeks post-op, we have a situation, it heals. Epithelium grows 0.5 millimeter a day. 3 months post-op, now it's time for me to uncover the implant. So what do? I take a tissue punch. Doctors, this is really important. What am I doing wrong here? What am I not respecting? Attached gingiva. I'm incising in the mucosa. This is a periodontal failure. So I'm in mucosa. I'm going to go ahead and take my impression, my analog impression, but I don't have attached gingiva. But let's create some. So I'm going to make an incision on attached gingiva that's resting on the crest. Remember, I need 2 millimeters of attached gingiva on the facial aspect of the implant. So I'm going to make an incision slightly lingual to the center of the crest to take that band of attached gingiva that's on the crest. I'm going to move it to the facial. Taking my Orban knife, and I'm making my envelope reflection. I am not reflecting the lingual tissue, I'm simply taking that attached gingiva that rested on the crest, and I want to move it to the facial aspect of my implant. I'm going to put a 5 millimeter tall healing abutment. This implant is integrated. I'm going to torque it to 25 Newton centimeters. Now I'm going to take that attached gingiva that was on the crest, and I moved it to the facial aspect of that healing abutment. I'm taking my reverse cutting needle on the mesial facial, and I'm not engaging the lingual tissue. Rather, I'm wrapping it around that healing abutment. Dr. Han created these healing abutments precisely so that we can do what we're doing now. I'm then going to take my reverse cutting needle and go distal facial, not engaging the lingual tissue, and coming around that healing abutment to the mesial facial and tying my knot. So I now took that tissue that was on the crest and I moved it to the facial aspect of my healing abutment. I don't have primary closure. I don't care, because why? Epithelium is going to grow 0.5 millimeter a day. The patients have no symptoms here. This is not painful. Bone is exposed. Let it heal. 3 weeks. The team at Glidewell sent me the final crown. Doctors, you are going to achieve this routinely. I know I'm talking fast. We're going to cover a lot of this in the symposium, Dr. Park, where we can go into a little more detail. We place the screw retain Bruxer crown, torque it into place, cover it over with composite, and we're able to provide the patient what they needed, what they wanted at a fair cost to them, respecting bone and soft tissue. You're going to have an outstanding long-term result. There are no shortcuts to be made in implant dentistry today. You want predictability, you have to follow the rules. And hopefully the short time that we've been together gives you some food for thought to make you better practitioners. Thank you, Dr. Park. I'd be happy to address any questions with everybody.
Yes, sir. Thank you, Tim. Another great lecture. We have a bunch of questions here. Let's just jump right in. So, a lot of questions about the Osteogen plug, using the Osteogen plug, and I know you're very experienced with that. So the first one is kind of simple. Can you still bill for a bone grafting procedure if you're using the Osteogen plug? You know, you're not using particulate bone or a membrane. You still call it a bone graft.
It's a bone graft. It is absolutely a bone graft. It is not. It's a graft material. You don't bill out for a membrane.
Exactly. It's a what part? It's Achilles, bovine Achilles tendon, and
Yes.
crystalline.
Calcium apatite. Calcium
Yep.
apatite.
Calcium apatite crystals. Excellent. Excellent. So yeah, it is absolutely a bone graft. And then just on the procedure, because I think the procedure was a little different than people expected to see, right? So you're curating out the abscess, the granulation tissue, preparing the osteotomy, and then you're placing the osteogen plug, and then you're placing the implant right into the plug. Is that correct?
That's correct. And that material allows it kind of pushes out of the way and it fills that gap. The literature is really clear on this. You know, when you have a gap greater than a millimeter, the literature says we should graft. And we can use an alloplastic material. If you use alloplastic, you have to protect it from invagination of epithelium just because of the particulate size. And sometimes challenging to thread into allograft material. It just moves out of the way. It makes the procedure so simple.
So you're basically, if you're filling the socket with the oxygen plug and then you're placing the implant, is there some fear that this extra pressure you're placing could actually injure, let's say, the a thin plate on the facial?
No, I don't. No,
Okay.
no. It's not a hard graft material. It's spongy, and when the blood, you have to have bleeding. Blood is really important. Thank you for bringing that up, curetting. And but when blood absorbs into it, it's rather soft.
Okay. And you showed some cases where you did one stage where you placed a healing abutment, and then you showed case where you did two stage where you placed a healing screw and covered over. How do you decide which one you're going to do?
Okay, yeah, that's a great question. Number one, if we achieve 25 Newton centimeters of torque, we can place a healing abutment. A healing abutment is simply a taller screw that penetrates through the soft tissue that allows the tissue to form a cuff, eliminates the need for secondary uncovering, eliminates the need for anesthesia. So if I'm able to do that, I'll congratulate the patient. When wouldn't I do that? Smokers. Smokers, bury the implant, protect it. I showed you two cases where I put a collagen plug on top of it. Let the epithelium grow. Just try to protect it. What's another reason? Patient's wearing a partial now, metal framework partial. It's had it for 20 years, right? They're comfortable with it. I'm going to place the implant, bury it. Let them wear their partial during the 3 or 4 months that they have to heal, rather than me grinding out, metal or the framework. So it all depends on the patient's habits, how big things are. We don't want to put pressure. We don't want to put pressure on the implant. Neil, and sometimes the healing abutments are tall where it bothers the tongue. And the tongue is the second strongest muscle in the body. If there's a foreign body in there, the patient's going to play with it and they could potentially lose the implant. So you kind of have to get a feel for your patient.
Right, right. Okay, just it looks like we're still not clear on this. So the question is, how do you not drill away the plug when you're placing the implant? But you've already drilled for the implant. The osteotomy has already been made when you
Correct.
place the osteogen plug, and then you're putting your implant into the osteotomy that you already made.
Let's yeah, that's correct. And take it another way. Let's say, okay, I have a defect and I place the implant. I could put the graft in afterwards, but that's pretty hard to do.
Right,
It's how do you know you have no control of it?
right. Okay, and but so do you have any trouble finding your
No,
osteotomy preparation through the just you said
no.
it's a soft material, you just kind of push through it.
You know where you drilled in. You
Yep,
know where it is. It can only go in one spot.
right. Okay, and you haven't had problems with it changing direction. It looks like there's skepticism here. We're getting a lot of questions. But I know
Okay,
you've done a
and
lot with
that's
this technique. So
but Neil, that's real important. It's important. Remember again, concentric circle. Our stability is in the apical 2 millimeters. When you make your osteotomy, that implant, you're controlling it. Okay, you're thinking tooth. You know exactly where that implant needs to be. Okay, it can only go in one spot, and you're going to get your stability in the apical portion.
right. So even though let's say the osteogen plug has sort of obliterated your osteotomy that you prepared, you're not having any trouble finding it because you know where it is. You know which direction you're going.
Yes, sir. Yeah.
Right. Got it. Got it. Okay. Um, yeah, you mentioned going 1 millimeter subcrestal with an immediate implant in the anterior, but obviously the facial and the palatal bone is usually at different levels. So you're talking about 1 millimeter subcrestal from the anterior, right? From the
Correct.
facial.
Yeah. Yeah.
Okay.
Yeah.
All right.
And yeah, absolutely. Yes.
All
Because
right.
physiologically, we're expecting some bone loss. And again, that's why Dr. Hahn designed the implant with that machine collar. That was all very, very important for him in the design of the implant. That's what makes the Hahn implant so special.
Great. And I've got two kind of general questions about implant surgery that I know you're well qualified to answer. The first is, do you recommend chilling the irrigation solution before you do a surgery?
I've heard that. I probably not a bad idea. I don't. We do so many surgeries. Neil, you get all our pictures. You know how many surgeries we do in the course of a day. I don't, but that's not a bad idea.
You got to keep it somewhere. You might as well keep it in the fridge, right? Okay. Good, good. And then just in general, right? You're drilling your osteotomy. How do you make sure you don't accidentally hit the roots of adjacent teeth? What's your basic technique?
You know what? That's great. That's what we teach, the recipe. So, and I know I've talked fast today. You have an edentulous space. Number one, think tooth first. You're evaluating your radiographs. We're dentists, we're doctors, right? We're we're doing our CBCT analysis if we need that, and you're making a pilot hole, 1.5 diameters, 4 millimeters in the bone, and stop and take an X-ray. You're going to know your angulation. Are you heading towards that tooth, or are you dead center? You know where the implant needs to be. Don't be afraid to take radiographs. You can't do implant dentistry without radiographs. You know what, Neil? Stand up and look at it facially, lingually. Nobody says you can't get out of the chair and look, making sure your angulations are correct. I think
Right.
I think Dr. Tilley's going to do a program on malpositioning of implants and things like that. That should be a really good webinar for you.
Excellent.
Um,
Excellent.
so,
Yeah, I mean, listen, you've got to take an x-ray so that you have a really good idea of the direction of those adjacent roots so that you can parallel them. If you're parallel, you're never going to hit it.
and you know what, Neil, and there's nothing wrong with aborting too. If you feel stressed out, if you don't feel comfortable, just stop, suture it up, come back another day. This should be a fun thing and a calm thing. It should become routine for our listeners here.
Okay. Okay, if you're doing a sinus bump, would you still use an osteogen plug or would you use particulate?
I've done both. I've done both, either or, depending on what photographs I want to take that day.
Right.
Uh, the both materials work equally as well, and I'm comfortable
I mean, that
using.
sinus membrane has osteogenic potential, right? So if you just maintain the
Absolutely.
space with the oxygen plug, you should get fill.
Absolutely, absolutely. And you can we can and the material is such that it allows you to push up that Schneiderian membrane nicely. It gives you a lot of control. When we do Caldwell Lux, I really like it, where particulates kind of goes all over and you're trying to pack it, and it's easy to perforate.
Right, right. Excellent, excellent. What about PRF? What situation do you use PRF?
So, PRF is wonderful. We do a lot of sedation dentistry in our bigger cases, and if the patient's sedated, and I'll do it, and we'll spin it and we'll use it. A lot of my bigger cases, it allows me to provide to create platelet-rich fibrin with a membrane, or platelet-rich plasma, which just stimulates the growth factors. The results are faster, not better. It's just faster. It may save me a month, 6 weeks, in the procedures. For me to do it routinely with the number of implants that we do every day, it's a time restraint thing for me, but it's a wonderful system, and it just gives you faster healing. Absolutely.
Great, great. Do you ever take post-op CTs?
Well, I'm an educator, as you know, Neil, and so we do for education purposes. I think it's a good idea. I had a doctor just yesterday call me in the anterior, in the symphysis area, on an elderly patient. Challenging. Okay, well, how do you got to get that position just right? And I said, take your pilot burr, put them back in the CT, and see in the sagittal view where you need to be. A CT is a tool. It just makes us better. And if you need it, if you want to feel more comfortable, then do it. I mean, you could perforate the lingual concavity. If you're not sure, use the tools available to us.
That's really well
Document.
put. Yeah, I mean, it's a risk benefit computation, right? If the benefit to the patient is greater than the risk of a little bit of additional exposure, then go for it.
And you don't charge for that, and our CBCTs are tools that make us better diagnosticians and better surgeons. They're not money makers necessarily. So, um, be smart. The end
What
result is
about
all that.
freehand versus digitally guided implant surgery? When do you use a guide?
Well, I think I showed you one case where it was a tough case, and I'll use a guide. The team at Glidewell is doing a great job. Um, Single units, I've been doing it a long time, so maybe 20% of the time I will use a guide. I use a guide when I need a guide. My full arch cases, what did we do last year? 54. I'm using a guide. I want to idealize the position. It makes me a better surgeon. It's a tool. It's a tool that makes us better.
Got
It's
it.
not a panacea though. It's not always perfection. And doctors need to know how to do this two-dimensionally, and they need to know how to respect attached gingiva, and they need to know to respect facial plate of bone. Those are important.
Yeah, you make quite a point of having an adequate band of attached gingiva. When you do that procedure where you pull that attached gingiva to the facial, do you bill that out as a separate procedure?
No, I don't. It's all part of it's the result that we want to achieve.
Okay.
If they
You're not a
came from
nickel
another
and dimer.
office,
Yeah.
yeah, if they came from another office, then I would, obviously, because you can do it post-operatively. But this is all part of the end result. All that matters is the end result.
There you go. There you go. Well, Dr. Tim Kosinski, as always, it is a pleasure to have you on the webinar. You bring great information, very, very practical, lots of great questions, and I know everyone appreciated what you did for us today. And we'll look forward to your next presentation, and of course, having you as well as Dr. Hochberg and Dr. Levin at our implant symposium.
Thank you. Awesome.
All
Thank you.
right, take care. Thanks, everyone. We're going to see you next week. Kathy Bassett is coming back. She was here a couple of weeks ago talking about anesthesia in the mandible. She was really well received, had a great deal of good information. And she's going to be back next week talking about anesthesia in the maxilla. And I know that's going to be a great lecture again. So we will see you then. In the meantime, everybody have a great week and keep practicing those guitar riffs. And we'll see you next week.